So, can you see my screen and can you hear my voice?
Yeah.
Okay. Greetings to all the colleagues from both sides of the world. I'm Regina Shrestha. I'm one of the HIEM trainees in emergency medicine. I'm currently posted in pediatrics emergency medicine in Nepal, so I've chosen the pediatric topic, that is febrile convulsions, that falls in according to the 2021 HIEM curriculum. It falls under neurology, categorized as NeuC3. And all of my colleagues who are following the old curriculum for ARCP, it falls under PMP6 and PAP9. So starting with the pre-session questionnaire, I've sent the link in the WhatsApp group and also in the chat box. If you follow this link, they will ask you the room name, and that will give you the pre-session questionnaire. You'll be accessing shortly.
Rosina, I can't find in the chat section. Is it in DRI-EMTU or somewhere else?
EMTU. Are you in the group? Or you can access the chat box as well.
I don't see any of your posts regarding that link, so I'm not sure which one to choose.
Rosina, it asks for a room name, student login.
I'm going shortly.
Okay.
Now the activity has started.
Can you send that link again in the DRI-EMTU link, please? Like in the chat, WhatsApp chat. So what's the name of the room then?
The name is Shrestha 2160, as you can see on the screen.
SHRESTA 2160. Right. Okay, let me know.
Oh, there's a QR code if you like.
I chose the other option, but I'm not that old enough for the QR code. But anyway, I've got it now.
Can others access as well? Sushil, picking up randomly. Marius.
Muted.
Just put a thumbs up when you are done.
Me and Tilak, we are doing from the same link.
Which room is it, Rogina? Is it room?
Shrestha 2160.
Sorry?
It's on the screen if you have Shrestha 2160.
Yeah, I've managed to get in and I managed to complete it.
Okay, that's good. Rain's done. I'm going to stop now. Is that okay? So I'm stopping the quiz now. It's still going on.
breach of confidentiality in this pre-question.
Okay, then.
That's actually right. Yeah, Sushil pointed it out. But within the group, though, that's absolutely fine.
Confidential. Not breach.
Yeah, yeah. She actually managed it accordingly.
Well done, Rosina. But we already know now.
So still one more. So yeah, so this shows the need of the class today. The maximum 60%. Okay.
Is it maximum 60%?
I know the top one is Amitabh.
Yeah, the correct one is maximum 60%. So after this class, it will
Who got
increase.
all 5 wrong? Rosina, you should make them write reflection.
Yeah.
No. So starting the presentation now. So the learning objective of today's presentation is to overview a case of febrile convulsion that I saw in Chittagong Medical College, and to discuss epidemiology, etiology, risk factors, definition and types of febrile seizure, febrile convulsion seizures, and overview the assessment and management of febrile convulsions, and also the hospital admissions criteria and etc. So starting with the case VNet, this was a case seen in the emergency department of Chittagong Medical College and followed up in the pediatric ward on the 7th of March 2022. There was an 18 months male baby brought by the mother with a chief complaint of fever for 1 day, cough for 1 day, and seizure 1 episode that lasted for 30 minutes before arrival in ED that lasted for 2 minutes. Was described by mother as generalized clonic uploading of eyes, and the maximum temperature recorded was 38.9 Celsius. On primary survey, the general conditions, the baby was alert and playful on arrival. Observations wise, the respiratory rate was 34, heart rate was 150, temperature was 99.8, and saturation was 100% on room air. There was no abnormal finding on the systemic examination. So any guesses what is this? Of course, it's obvious. Okay, no answers.
Febrile convulsion, is it?
Yes. Yes, Mr. J. So regarding the epidemiology of febrile convulsion, it is one of the commonest presentation in pediatric population in ED. It's a commonest presentation in emergency department in UK and in Nepal as well. And it was one of the top 5 presentation in the emergency department where I'm working now. Record shows that recorded by Sheffield Children's Hospital, there is 2 to 5% of children in UK have at least 1 febrile convulsions, whereas in Nepal, the study is a bit old, done in 2011, but it's a bit more than the UK, that is 6.6%. It mostly occurs between 6 months to 3 years, and the peak incidence in 12 to 18 months. Can anyone tell the definition of febrile convulsions? Let me find somebody. Nobody is.
Marius can tell.
Sorry?
Is a Marius there, is it? Marius.
Marius.
It's less than 5 minutes.
It's
No?
it's the fit caused by fever, is it caused by high temperature?
Yes.
Seizure in a child for less than 5 minutes, secondary to a fever, but the child should clearly be non-epileptic, and it should be maybe non-traumatic, something like that. But mainly between 5 months to 6 years, less than 5 minutes, and fever and non-epileptic child.
Yes,
If I may include one, so no cause, no neurological abnormality could be found out in those
On examination.
patients.
yeah, that's very important point. The febrile convulsion is a seizure that is occurring in a child between 6 months to 5 years, especially not 6 years, but it's 5 years, which is, of course, precipitated by fever, usually more than 38 degrees, and the infection outside the nervous system. And as Suraj I told that it is the patient should be neurologically normal. There's a short video for the febrile convulsion of a child. Is it playing in all of our screens?
No.
No, actually.
Okay, let's skip that then. So the cause of the febrile convulsion could be, of course, there would be fever predisposition for the febrile convulsion. The age, as we discussed earlier, it is between the 6 months to 5 years, and it is most peak incidence is between the 12 months to 18 months, as seen in a child discussed in the case FINET. And the fever, the rate, rather than the grade of the fever, the rate of the escalation of the fever is main cause for the febrile convulsions. And for the genetic disposition, if there is a positive family history, and also in the siblings, and if there is a both parents have a history of febrile convulsion, the child is more prone to the febrile convulsions. And genetic wise, it is linked to the genes responsible for the sodium channel receptors, and it is strongly linked to the chromosome 2q. There are different chromosomes related linked to this febrile convulsion, but the strongest linkage is to chromosome 2q. And there are different types of febrile convulsions in the complexity, in the features of the convulsions. There are benign, simple benign febrile convulsion, complex febrile convulsions, and febrile status epilepticus. If the convulsion lasts for less than 15 minutes, doesn't occur within the reoccur within the same illness or within 24 hours, then, and it is isolated generalized tonic-clonic seizure, then it is categorized simple benign febrile convulsions. And if it is more than 15 minutes, the partial focal onset and focal features, and the recovery is not within 1 hour, or there's more convulsion per episodes of fever, or within 24 hours, it's classified as complex febrile convulsions. And whereas if it is last for 30 minutes and there's no full recovery in between, then it's called febrile status epilepticus. It's simple. The classifications and types is important for the management. Rather than management, it's whether the patient needs a hospital admission, whether the patient needs to be extensively investigated. It's important as well, and also the determining the prognosis and recurrence. The type has to be recognized. Regarding clinical assessment, anybody can tell me what is important in the clinical assessment? Is Samir there?
Lack of oxygen.
I think it's low birth weight is a risk factor for febrile. Prenatal history as well.
No neck stiffness should be.
No, why not? Why not? We will see if people are breathing or not. Given oxygen, prevents secondary damage to the brain.
Yeah.
But most of the times, aren't these children already recovered by the time they get to the hospital? So basically, their examination, apart from a bit of fever, maybe a bit of tachycardia, and the source, that's not neurological. They should otherwise be okay, isn't it?
Most of
Still,
the
we try to look for the focus
Yeah.
of infection and then just make sure there's no other neurology.
Yes, correct. As Marius and Sushil told, by the time the patient comes to the ED, the seizure has been seized, and it's hard to believe the parent telling the history whether it was not. So, but it's important to rule out the focus of infection, and also it is because most of the seizure has been stopped. Then the eyewitness account is very important. The conscious level before the convulsions, what was the characteristic of the seizure, what was the recovery time, in the child, and also the state of child after the seizure. If there is a post-ictal, then is most likely period. It is likely to be febrile convulsion rather than other differentials. So also the main focus of the infection has to be ruled out. Also the symptoms of meningitis, like rapid illness of rapid onset of illness, or floppiness, vomiting. Of course, there's a fever and neck rigidity, etc. should be ruled out. And there might not be typical symptoms of meningitis, so everyone has to be taken history and clinical examination properly to rule out that. And there's a risk factors from the family history and also the risk factors of the previous febrile seizure. That is a chance of recurrence in the patient. So the past history and family history is also important. In the examination, of course, the ED assessment starts from the ABCDE and assess and treat according to that. Also the observations, and if there is any rash or focus of infection, meningism, as discussed earlier, or fontanelle in case of the infants, and the conscious level is important in the examination. Let me ask. So what are the investigation important in the case of febrile seizures?
Sodium, potassium, blood glucose.
So you need to do infection screen
I do a BM.
and hypoglycemia
Yeah.
and the capillary blood capillary oxygen.
So according to the guidelines, all the routine
X-ray.
investigation, yeah, X-ray as well. All the investigations are not routinely indicated, but blood glucose should be done in all cases, as in every case of seizure or unconscious patient. The investigation, rather than the seizure or seizure, the investigation should be done to rule out the causes of the fever and the source of infection. So the urine test and chest X-ray should be done if there is considered no focus of infection, and but the CT and EEG are not helpful in most of the cases. The lumbar puncture should be done if there is any signs of meningism. If there is a less than 12 months, then it's highly there's a high need of doing the lumbar puncture. And if there is less than 18 months, then it should be considered as well. And the patient is systemically unwell, and if there's no finding of the focus of infection and there's a history of complex febrile seizure, then the lumbar puncture is needed as well. Other differentials that mimics febrile convulsions are rigors, syncope or breath holding spells, apnea or post-ictal fever, and other causes of seizures like meningitis, encephalitis, hypoglycemia, epilepsy, etc. Regarding management, anyone can start with the management in ED.
If the child is actively seizing, then we have to follow the seizure protocol. Otherwise, usually just paracetamol.
Get the temperature down.
Yeah, just
if they're put oxygen on, oxygen on, connect pulse oximeter cardiac monitor, give some SPOSI to keep the temperature down. And then if still fitting, so stop fitting, by PR, diazepam, or what the situation is, IV line, starts, optimizing glucose fluid. So I think if they're still fitting, so then you start working on the unwell child. What would we do for the unwell child?
Yeah. So as we discussed earlier, the febrile convulsion, the seizure will be already stopped when most of the seizures will be stopped on ED presentation. Of course, with the child is still fitting, we have to follow the algorithm. Sorry, for the poor quality of the image, the best I could get was this from HIEM curriculum. Oh, sorry, HIEM learning. Of course, within 3 minutes, we have to take care of ABCD, oxygen, and BM, and address the BM if it's low, and gain access as well. And then within 5 minutes, we have to, if the patient is still seizing, then we have to go for benzodiazepam, either lorazepam, or if there's no access, there's a buccal or rectal midazolam diazepam respectively. And in another 5 minutes, if it is not, the patient is still seizing, we have to go repeat the benzodiazepam. And the HIEM learning focuses on saying loudly that we will wait for 10 minutes until the medication has worked, so that the parent and other would not panic and we give the time for the benzodiazepam to work and not overload the child. Otherwise, because the overload of the benzodiazepam will end up in intubation of the patient. So, and subsequently, if the seizure is still going on, then we have to go for the second line, phenytoin or levetiracetam. And also, if it is not working, then we have to go for RSI. That is the management for fitting child. And for the fever management, though we have taken sponging in the case of fever, but it has been reported that tepid spawning, cool bath, and fanning causes the vasoconstriction that will increase the temperature, and the child will not improve. For the fever, all we can do is paracetamol. It is an effective antibiotic in case of febrile seizures, and adequate fluid intake. And any idea who are the patients that should be admitted in the hospital?
I think first febrile fit should be admitted, and then complex febrile convulsion should be admitted, and others should be like non-clinical components, probably parents related. But those two are the main things.
It also depends on the age, is it? So infant in the first year, they are a bit risky children. So if you're absolutely sure what's happening and the child get back to normal, everything. Otherwise, so we have to be cautious discharging them in the first year of life.
So does all first fit get admitted?
Not essential, no.
So I think all first fits should be, if you are fitting for, if the child who is not known febrile convulsion comes in with the first febrile convulsion, they should be referred to pediatrics for further investigation to be sure. Because in A&E, we cannot just be sure it's purely febrile convulsion. You need to, unless you want to do all.
So does anybody know that our local trust policy, Doncaster Bassettler trust policy, what does it say?
I don't know what the trust policies say in Doncaster, but from my previous pediatric experience and postings, if a child is fitting for the very first time, if they are not known to be febrile convulsion, if they are coming for the first time, you should refer them to pediatrics, because they need to be sure that it's purely a febrile convulsion and there's nothing else. Is it malaria? Is it meningitis that doesn't have a rash? Or is it is it an electrolyte problem? So they will need to have bloods and everything, unless it A&E want to do all the investigation. But I will refer all first fits to P.
So that our local policy suggests if not all first fit are referred or admitted. So that's why we have got also a febrile convulsion advice leaflet. So if a child completely resolved, child is clinically stable.
I'm sorry.
I disagree
Or
with
you are
Olu's
able to.
opinion. I think a child who is clearly having a fever, who then had a limited, self-limiting seizure, and by the time you quite often by the time you see them, they have fully recovered and they are well. At that point, there's really no need for any referral to pediatrics. I have spoken to pediatrics before about this, and that's the guidance that they go by as well. So unless you have some concern about other non-febrile, other reason, non-febrile seizure type reason for the seizure, or they have multiple seizures like what Regina was saying, there's really no need to refer on to the pediatrics.
Thanks, Boone.
Especially first.
And what rightfully said by Boone, that is what our local, if you go to our internet, you go to the pediatric site, you check that. So all febrile convulsions, first fit, first febrile convulsion doesn't need to be compulsorily referred or admitted under pediatrics.
It's very much depend on the clinical condition, I say. I mean, if the child is young and is still unwell, of course, these children are a bit risky. You don't admit them. But if a child is toddler,
so that is a criteria, Mr. J, you're saying about clinical concern. So that is what Boone mentioned. If you have clinical concern and say suppose extreme age like infant, neonate, obviously neonate, anything below 3 months, invariably whether there is a hypothermia or hyperthermia, protocol is to refer to pediatrics. But other than that, simple febrile convulsion settled, we usually send them home with an advice leaflet and safety netting.
I just posted the SCH guideline. Basically, they have a febrile convulsion guideline. They mentioned clearly in one of the PDF that I've found out. I can share that as well. So what it mentioned is like there are certain reasons if even after the first fit, the child can be considered as an for admission if there is no obvious focus of infection, complex convulsion, child less than 18 months old, parent request admission, or raised parental anxiety. The reason is I want to focus a little bit more from the parental aspect because I got a child with febrile convulsions. So we had a difficulty to start with because from the first convulsion, we were kind of informed about what can happen, and we were actually kept admitted for watchful observation because ours was like a little bit about 11 to 14 minutes, kind of like a what they call as an atypical febrile convulsion at the time. So they didn't do any particular investigation, but it was more of watchful observation just in case to reduce the fever and see whether she gets better or not, which she got. And on discharge, they actually gave us buccal midazolam as a prophylactic basis. If it happens again within the 5 minutes, right after 5 minutes, you need to start that buccal midazolam because wait until the 5 minutes because usually it gets settled. If it doesn't get settled, at 5 minutes time, you give that buccal midazolam and then call for an ambulance. That is what the response they had.
Yeah, thank you for the input. I did not get access to DVTH protocol, of course, but I got access to the Sheffield Children's Hospital as written in the chat box by Suraj. There's a similar first febrile seizure as he told all of that. And if there is no first febrile seizure, if it's not first febrile seizure, if it's a complex seizure less than 18 months, recurrent febrile fits that needs hospital admission as well. And if there is any concerns, clinical concerns, and of course, if there is a patient needs to be discharged, then parental advice is very important about what needs to be done if the patient sees again. there had been a debate whether anticonvulsant prophylaxis is needed or not. Actually, there is no evidence that it prevents convulsion in future, not recommended in the neurological normal child. But if there is a risk of complex seizures, buccal midazolam can be issued to the parent with detailed instructions, as said by Suraj Dai. As I said, the parental education is important. Education and counseling is very important about the nature and prognosis. Of course, when if your child comes with having a seizure, the parent may be very much distressed, thinking that it's a very sinister. But they need to be explained that the febrile convulsion has good prognosis, and if the patient is to be discharged, going to use anticonvulsant and also reassurance. And febrile convulsion is also common after the immunizations, but it should not stop immunization schedule of the child. The prognosis is good, but if there is a family history, onset less than 18 months, if there is a low temperature, the febrile convulsion came at even at the low temperature or the low duration of fever at onset, then the prognosis, there is a chance of recurrence. But however, the parents should be counseled that the intellectual capacity of the patient is not affected, and there's no evidence of the increased risk of death even for status epilepticus, according to the NICE website. And febrile seizure recur in 30%, and only 2 to 7% of the children with febrile seizures will develop epilepsy in the later years. So the outcome of the case I mentioned in the beginning, 18 months, he was admitted in the pediatric department. The investigation was done. BM was 6 millimole per liter in the ED, and the blood investigation that was subsequently done in ward. The HP all were good. The WBC is slightly raised. Otherwise, the procalcitonin was done, which was negative, and urine RE was normal as well, and also the RFT as well. And the patient was admitted for 3 days. He had 2 spikes in the first day, the maximum temperature being 101, but there was no seizures while he was admitted in the hospital. He was treated with paracetamol and IV fluids, the 80% maintenance fluid, and there was no recurrence of convulsions throughout the stay, and the patient was discharged on the 3rd day admission with planned follow-up, and also the education to the patient. So take-home message from my presentation today is a common presentation, and the history and clinical examination is very crucial in the diagnosis, and the focus of infection needs to be investigated so that we don't miss out the sinister diagnosis such as meningitis, encephalitis, and the febrile convulsions has a good prognosis, and parent education is important on discharge or even on the admission. These are my references. So there's a post question. I'm going to start a post questionnaire. Hopefully the percent will be increased. So I'll start the room for
Do we need to do anything for post questionnaire, or just wait for your instruction?
Yeah, just log in with the same login ID. Whoever is using the same link and the room name is the same. QR code. You are comfortable in using QR code. Let me know when I'm finished. Oh, sorry. Welcome, Dr. Biraj.
Hello, everyone. Actually, sorry for joining your presentation a bit late, but I was able to catch from middle of your session and few comments.
Sir, he's he's a pediatric intensivist in Chiton Medical College, where I'm posted, and he's my supervisor.
I went through with your presentation. So a few comments which I want to make is the management in case of febrile convulsions would be determined by how the child has presented. Is it just a febrile seizure? That is, the seizure has occurred outside of the hospital and the patient usually comes in the post-ictal stage. Right? That is the most common scenario which you get. The other thing which we get is a febrile status epilepticus, right? The patient actively seizing, present to us with actively seizing. So the management will be a bit different because as I think we have already discussed how to go about the case of febrile convulsion coming to emergency department, and in that time probably you just manage the ABCD approach because the seizure has already occurred. But on the other side, if the patient presents to you with febrile status epilepticus, but in those cases we have to start with the anti-epileptic to control the seizure. So it depends upon case-to-case scenario, and the indication of admission, at least in our part of the world, is the last, I think the last two option, that last two reasons, that the parents be asking for admission and the parents anxiety that becomes the most common indication of admitting a febrile convulsion apart from the febrile status epilepticus. And we've discussed about the different causes or the differential diagnosis of a febrile convulsion child. And one subtle finding which you can, it's not a evidence proven thing, but once a child comes to you with fever and within 24 hours of fever throws a seizure, right? So that in that case, the meningitis is very less likely. Right? The reason for having a seizure in a febrile child is the sudden rise in the temperature rather than the degree of temperature. So sudden rise in temperature within 24 hours, most likely it's a febrile convulsion than a meningitis. Meningitis will take a couple of days of fever, then only the meninges get involved. So that can be a subtle marker in which you can differentiate between a meningitis and a febrile convulsion. And as Rosina has already mentioned about the need of doing a lumbar puncture, the textbook writes before 12 months, there is not much of a myelination. Probably we need to do lumbar puncture in most of the case. From 12 months to 18 months, you take clinical parameters into consideration while taking a decision for doing a lumbar puncture. And more than 18 months, if you assess, if your examination is suggestive of a meningeal irritation of meningitis, then probably we can go for this lumbar puncture. And one more thing about the anti-epileptic medication for the controlling of the seizure. So most of the time, what we have is whenever a patient comes to seizing into the emergency department, most of them will not have any IV access. And the recent evidence said that intramuscular midazolam 0.2 mg per kg is the drug of choice for aborting the seizure more than IV lorazepam or more than IV diazepam. So we've been also practicing for the last few months or so, and it's working very good. Not the IV, but the intramuscular midazolam 0.2 mg per kg. It's better. It's evidence proven thing that it's controlled the seizure better than the IV lorazepam or diazepam.
Yeah, thank you very much. Yeah, so I think the points made are valid, but I think in here, once we define is a febrile convulsions, so then the admission, when we think of admitting, then we take the risk factors. So what are the risk factors in this particular child? because febrile convulsion per se doesn't need admission, because the febrile convulsion, there's nothing there. People are okay now. So admission is a bit hard to justify. Having said that, then you think of the risk factors, which you are mentioning that if need anticonvulsants, or the people have got some, error of metabolism, or the people are non-epileptic, or there are risk of something else like meningitis or cerebral malaria and that sort of stuff. Of course, these children need admission. And we also take into account the age as well. Very young kids who are coming with febrile convulsions and, they are still a bit unwell. So we do admit them, but we don't admit like, as 100%. No, the pediatric won't admit these kids. Of course, the other option is in here that if we are worried about, or the parents are worried about, then we request the pediatric people to come down to A&E, which is not far away. Then they can assess and then they can make their mind. And then they can convince the parents that, your child is well, we assessed it, everything is okay. So this is the advice, go home. If something happened, just call 9 and bring the kid back. I think it's a bit of a relaxed approach. So there's no rigid approach that every febrile child will be admitted. But I think we should think of the risk factors, what the risks are. And, if we take it from there, then we won't go wrong.
Thank you for your input, Dr. Biraz and Mr. Geneva.
Regina, I think it's very important to see the child how is clinically in the moment, not just to admit, but if it's just febrile convulsion. I understand was less than 5 minutes that was febrile convulsion. If it's longer than 5 minutes, then it's necessary to consider epilepsy. And if it's repeated also more than once, no, just isolate and very short convulsion, and also with the fever that is 40 degrees or 39.5 that they can get very easily convulsed. Like Mr. Joan just observing in a young to see if it's repeated is the child. After that, and you give antipyrexial medication. If the child is interacting, is well, and is not any you see that is okay. Meningitis goes very, very quick, very well, child, very quick. And also you can in the examining clinical and also risk factor is important to take into account when you see the child.
Yeah, I just want to touch base upon the actual age spectrum that we should be worried about. I just checked the NICE CKS guideline as well, and it mentions 6 months to 6 years, which is what we have been told by the child neurologist over here, who we go after. So I think there's a little bit of changes in there. So whether we want to be rigid with 6 months to 5 years, or at least like have that 1 year of spectrum to actually have a look at whether that child will actually present it, because it's probably that time afterwards, then you start diagnosing epilepsy rather than within that time period. So it's a bit of debatable at the moment, because the NICE CKS actually mentions it's 6 months to 6 years actually. So based on that, probably I got one of the questions wrong.
Is it from NICE guideline?
Yeah, so NICE CKS, we check the NICE CKS and the definition of it. Yeah, so I can
Regina,
post that in here.
Regina, is it possible to? Sorry, Regina, is it possible to display those questions and then we'll go through the answers again?
So that was the link I was talking about earlier. So
it's just one question. It's just midazolam is because midazolam is acting very short, and then the pediatrician they can review very easy the child after and not sleepy. He doesn't get too sleepy with he's getting very sleepy with lorazepam. Then midazolam also in Spain they use because it's very short acting, and then they can examine very well the child.
Matter, the reason why we use midazolam is just the roots. So you can already use diazepam or midazolam depending on the roots. So
for the age group, I refer the HIEM learning pediatric seizure. It says 6 months and 5 years. That's what I
Right.
followed.
Right. Okay. That's absolutely fine because we follow the HIEM ones, but the overall like 96 years. That's why the mixed kind of picture there. That's absolutely fine. But can you actually check what date that is? Because it might not have been a recent.
It's an old one.
2021.
Publication date 18.
Yeah, I think that's kind of revised nowadays. I cannot say 100% for sure, but I believe that has been revised to 6 months to 6 years rather.
HIEM says, let's see, because if it comes out in an MCQ for those taking exams, these are typical MCQ questions, you know. So it's good. It's good to say the right thing. I think HIEM said, let me just have a quick look again.
So these are the other answers.
HIEM learning. HIEM learning says 6 months to 5 years on HIEM learning.
Okay.
So on HIEM learning, it says 6 months to 5 years.
So is that the date 2018 or 2021 or 22?
This is, you know, from the HIEM learning, you know, if you go to HIEM learning, if you log into HIEM learning, you know, it's current. It's an, let me see what date the article was written. But it's a current article. If you go to HIEM learning.
No, the question is, yeah, or the question if it's this MC common exam.
Exactly.
Take 6
so if it comes to an exam, HIEM learning, pediatric seizures, I'm reading from HIEM learning. If I can, let me see if I can share my screen.
So we should take 5 month one, not the 6 month one.
Let me just, I'm sharing my screen on everybody so you can see. So that's HIEM learning from the page, active page. And the answer is febrile convulsion is common between 6 months and 5 years of age.
Yeah, so we take 6 month one. Is it not the nice one?
Olu, what's the date?
Same, is it?
What's the date of that article? Just check the date.
So, you know, on HIEM learning, this is it. There's no date here. It just says author. But let me go to the bottom, see if it is signed at the bottom.
Because what Suraj is stating, he's saying nice guidelines. That is the updated guidelines. So maybe this is in due process for updating.
Take the nice one. Yeah, in exam, take the nice one.
Okay. Well, okay.
Because we have to follow the updated guidelines. If it is what Rojina is saying is the Royal College article is 2018 and NICE is suggesting 2021.
Okay, all right. Okay, yeah, this one is published in 2018. That's right.
So that is not that is yet to be updated on Royal College. So NICE guidelines which says will be appropriate.
Okay. Makes sense. Yeah. Regina, can you go through the rest of the questions with us, please? If we have time.
When do we have time?
Yeah, we have time. We have time. This your session will be the last one anyway.
What happened to Patrick?
Yeah, Patrick got the dates wrong, so his presentation is not ready today.
Second question is simple benign febrile convulsion less than 15 minutes. Second.
Is that 5 minutes or 15 minutes?
15.
It's 5 minutes, yeah?
It's 5 minutes in the NICE guidelines.
Yeah.
I mean, in the
Regina, I think it's 5 minutes. 15 minutes is too long. Then will be febrile epilepsy. Is the difference the febrile convulsion between epilepsy and febrile convulsion that is different?
Convulsion is.
Is it for simple benign febrile convulsions, or is it for the treatment wise?
So nice guidance. Who knows what the nice guidance says? Because everything is changing, that's why. Suraj, I think you have the guidelines. Can you help us with it?
More than 5 minutes is epilepsy, and then less than 5 febrile convulsion.
Sorry guys, I couldn't access my computer audio. So when I saw this, SCH guideline about the febrile convulsion, and that was a review date of July 2022. It's quite fresh one. So basing on that, if I go to page number 2, it mentions febrile convulsion 6 months to 5 years over there. And if it's a complex febrile convulsion, then it's longer than 15 minutes. If it's a simple benign febrile convulsions, it's less than 15 minutes. And more than 30 minutes is a febrile status epilepticus. But there's no particular time mentioned for the febrile convulsion as a.
Can I put some input to this? I
Sure.
think the textbook which we, for a pediatrician, we in Nepal and India, we follow a textbook called Nelson Textbook of Pediatrics, which also has been mentioning 15 minutes as a cutoff for if the seizure persists for more than 15 minutes, it's not usually simple. So 15 minutes has been taken in the Indian Academy of Pediatrics guideline also. So we follow 15 minutes to define whether it's a simple or not simple, so or complex. So we follow 15 minutes here also.
Yeah, thank you. Thank you so much, sir. Thank you, sir. I actually just looked at the Mayo Clinic guidelines now, and it also says 15 minutes. Simple febrile convulsion, this is most common type, lasts from a few seconds to 15 minutes. So yeah, I think it's 15 minutes, yeah.
I confirm from the NICE CKS as well. And it says simple febrile seizures are isolated, generalized tonic-clonic seizures lasting less than 15 minutes. And that do not recur within 24 hours or within the same febrile illness with complete recovery within 1 hour. So it clearly mentions less than 15 minutes. So we need to follow the 15 minutes. Yeah.
Thank you. Thank you. Thanks, Regina. Well, I think 2 more questions. I think this has really been helpful because all this while I've always had 5 minutes in my mind. So thank you, Regina.
The reason I also got confused was because in the Oxford handbook also I clearly remember reading 5 minutes. So that's why I got confused as well.
Yeah.
Regina made it sure that we couldn't score 100%.
She's a very, very tough teacher.
Just one more question, Regina. The presentation was really nice, very good, very informative. In the history, because you have your supervisor also, he might also give an input to that. 2 questions I have. One is relevant to the history. Will the history relevant to the developmental delays or birth related any asphyxia earlier the child has got sustained, like developed any kind of cerebral injury? Will that history be under consideration when we are trying to assess a patient with febrile convulsion?
I think It is not related, but I'm not completely sure.
Dr. Viraj can give that input.
Yeah, I think it's not mentioned anywhere that, but you have to take one thing into consideration, that if there is any history of Bottas figure, any kind of congenital malformation, they will have a propensity of having seizure. So the chances of having seizure in those the chances of having febrile seizure in those cohort of patient will be more. It's something called fever trigger seizure. So whenever there is underlying something, they have a propensity of having seizure. So they will have tendency of having seizure more than the normal child. So we have to take that thing into consideration.
Thank you. The second question is, you said about the treatment was management for giving IM midazolam, which is more effective, particularly in children.
Yes,
but as far my knowledge goes, as per the pharmacokinetics of lorazepam, it is the only benzodiazepine which has equal pharmacokinetic effect, both given IV or intramuscularly. So that is why it is preferably used even in status epilepticus in adults, that when we don't have IV accesses, suppose we can be given IM lorazepam, because onset of duration of action and pharmacokinetics, both, that is the only uniqueness of lorazepam, that IM given has the same efficacy as IV given. So any evidence that distinguishes suggesting midazolam to be given in children IM preferably rather than not giving IM lorazepam?
Yes, sir. Actually, the recent meta-analysis, I'll forward a paper to Rojina. I'm actually not at home right now. So once I go back, I'll forward a paper to Rojina so she can distribute among you all that which shows that midazolam is better than the other two. So I think I'll forward you the recent evidences so all can go through it.
Sure. Thank you very much.
Thank you.
What about giving a PR?
PR midazolam, yeah.
Yes, sir, but PR is also PR. Even buccal also has been used, but the effectiveness of those has been less as compared to IM midazolam or IV lorazepam or IV diazepam. So they are in a state in which you cannot open IV access, or then in those scenario you can give, but the effectiveness of the others are better than the buccal or intra or a colorectal diazepam.
I think the challenge we have here is, I don't know if our ambulance crews are able to give IM midazolam, because these ambulance crews, that normally give
medicine. If we define the evidence-based medicine, so the third component of evidence definition is that it's acceptable to the patient, the culture as well. I mean, here intramuscular injection in children, a little bit people a little bit squeamish, so hence they prefer to use the PR route, and the PR route has been proven is blood supply, everything is quite effective. But the most important thing is, once we the fit need these set of measures, then probably we will also thinking putting intravenous access and trying to get some blood, and thinking of respiratory depression and start giving some antidote. I think once we are actively managing people, children, then I think intravenous access will also become a bit mandatory. I know it's difficult, but there are specialists in the hospital which can come and do it. I mean, if the fit is more than 15 minutes, so it's already, I would be involving ITU in that sort of situation, immediately. The 15 minutes or more is too long.
Yeah. Thank you. Sorry, Georgina, the last question, we can't see it. What's the answer? Which is true regarding management of febrile convulsion?
Which is true regarding management of febrile convulsion. Lumbar puncture should not be routinely done unless anticonvulsants should be started prophylactically all the convulsions, and immunization should be continued even though there is a history of febrile convulsion. So the answer is E, not A, B, C.
Thank you. Thank you so much. This has been very educative.
Thank you, everyone. Thank you for the input.
Thank you. Thank you, everyone. See you soon.